Nau mai, haere mai. Welcome to this module from the New Zealand Dementia Foundation's Dementia STARs education series. Dementia STARs is a series of 8 modules covering some of the most common topics that caregivers work with every day when supporting people living with dementia. You are an extremely important part of the network of people who work in dementia care, and we hope you find this course very helpful for your work. People living with dementia are particularly at risk from falls, but while falls are a real danger, they aren't inevitable. Often several factors combine to cause a fall, and there are things we can do to make the environment safer for the people in our care. In this module, we're going to look at some common sense ways that we can help reduce the risk of falls for people living with dementia. Dr. Susan G is going to talk us through how to help people at high risk of falling.
Tēnā koutou, e tipu aki ao ke murahiku. Ko G te whānau. Ko Susan toko ingoa. Ko tēnei taku mihi ngā tangata whenua o te rohi nei. Ka nui te mihi kia koutou. Nō reira, tēnā koutou katoa. Welcome to this Dementia STARS session on falls and dementia. I'm Susan G and I'm a dementia researcher and educator. I'm also the liaison officer for the New Zealand Dementia Foundation. Working in our field, we already know that preventing falls is important from the impact that we see falls having on the lives of the people that we support. Let's take a look at some of the big picture evidence about the huge impact that falls has in Aotearoa, New Zealand. We're going to do this as a quiz, and you might be surprised by some of the answers.
How much did injury from falls cost Aotearoa, New Zealand in 2021? The answer, $1.5 billion. In fact, $1,596,380,710, to be precise. What are the chances that someone who's aged 65 plus and is living at home will have a fall this year? Overall, 1 in 3, or 30% of New Zealanders aged 65 and over who live in the community, will fall at least once a year. While most people won't be seriously injured, about 5% of older people will end up in hospital or fracture a bone because of a fall every year. What are the chances that an aged care resident will have a fall this month? The answer, 1 in 8. A New Zealand study found 13% of residents had fallen in the last 30 days. What's more, half of the residents who fell injured themselves. Boris is 85. Morris is 65. They both fall. How much more likely is it that Boris will fracture his hip? It's 15 times more likely. The older we are, the more likely we are to fall, but also the more likely we are that we will be injured when we fall. Boris ends up in hospital with a fractured hip. What are the chances he won't be able to return home and will go into aged residential care? The answer, 1 in 3. Boris is in a hospital ward with 10 people living with dementia who've been injured in an accident. How many of them are probably in that hospital bed because of a fall? 9 in 10. An Australian study found that when people living with dementia were admitted to hospital due to injury, 90% of the time, the injury was fall-related. Falls are the #1 cause of injuries for older people. Can we help prevent falls among the people living with dementia that we support? The answer, yes. Today, we're going to be looking at lots of ways that we can make a difference.
Let's think a bit more about what makes people living with dementia particularly at risk of falls. Let me introduce Mrs. Zielinski. She's living with dementia, and this picture was taken when she was just getting up for the day, just before she fell. So why might she have fallen? Why might her dementia be making her more at risk? Well, there are 3 areas we'll look at: physical changes, behavioural and cognitive changes, and environmental hazards. So let's start with physical changes. Mrs. Zielinski's dementia may bring with it physical changes that increase the risk of falls. Dementia can worsen strength and balance and change the way that we walk, which is called our gait. People living with dementia are more likely to experience a whole range of challenges, like side effects from medications, medical conditions and frailty, vision problems stemming from brain changes, nutritional deficiencies from not eating well. These all increase the risk of falls. Now, as well as that, we have behavioural and cognitive changes that might make Mrs. Zielinski more at risk. Changes in memory, judgment, and the ability to plan mean that people living with dementia may sometimes move in ways that aren't safe. So that's things like not remembering to use their walker. That can be particularly likely at times that Mrs. Zielinski is distressed. Dementia also slows down processing speed for the brain. Now that means that sometimes when we might be able to save the day with our reflexes, a person living with dementia may not be able to do that in time. And the third group of factors is environmental hazards. Now, where does dementia fit in here? Well, people living with dementia may be less likely to spot and solve these type of problems. Often, several factors combine to cause a fall. So in our case, Mrs. Zielinski rushed to the toilet, forgot to use her walker, and tripped over her floppy slippers. We're going to look at some ways that we can reduce the risk of falls for people like Mrs. Zielinski. So we're going to be looking at how to move, improve, and remove to address common reasons that people fall. That's a great slogan from the Stay on Your Feet campaign from Western Australia. Move, improve, remove. We're also going to talk about 2 important times we can put this into action. The first is before we leave. So we think move, improve, and remove before we leave a person unattended. The second is when a fall happens. We use that as a chance to learn. We think about move, improve, remove to see if we can help prevent the same thing from happening again. Our first focus is move. Remember how strength, balance and gait can be affected as dementia progresses? Well, if we don't move and keep physically active, do you think our strength and balance will get better or worse? Definitely worse. People living with dementia may need more support to keep moving. Let's hear from Tracy Hawkes. Tracy's an occupational therapist and she's going to talk to us about supporting people living with dementia to move more.
As an occupational therapist, I'd really like us to think about movement and how important that is for 2 things. One is for a person's general well-being and the other one is it's a falls prevention method. So first is our general well-being. We want about thinking about moving because it relieves pressure off people's skin as they're moving around. We want to think about as they're moving around, they're breathing better. So it's better for their respiratory system. It's great for digestion, for appetite, for thinking about our drinking and hydration. It's great for our bowels and our bladder as well. When we think about it, for falls prevention, when we're moving around, we're keeping our muscles working, we're getting our balance on track, so we're not going to get deconditioned and we're going to prevent those awful falls that we don't want to occur. We need to be mindful that when a person has had a fall, they can fall into a bit of a cycle, and that cycle is, I've had a fall, that's quite frightening, so I'm now fearful of falling again and hurting myself, so I'm going to sit for longer or not move as much. I'm going to get more deconditioned. My risk of falling is actually going to increase. When someone's in that cycle, we need to consider that and validate that that person is probably a little bit frightened. Add extra support, but don't leave them sitting for those long periods of time or not moving. So we want to offer opportunities, keep engaging that person, but validate that emotional fear because they might go and fall again. I think we often think that movement is actually about walking or doing exercises, and it certainly doesn't have to be that. When we think about moving, I want you to think about every part of a person's body, because again, go back to that person's general well-being. If we've got people reaching up, brushing their own hair, they're moving their shoulders, they're moving their body. So I want you guys to think about how we can get a person to do as much as possible for themselves, even to the point of, don't bring a cup of tea. How about you invite that person up and actually get them to come with you? We're getting standing, we're getting movement, we're getting mobility. We're also getting engagement in life, which is going to be so much better for that person's well-being.
Here's 3 ways we can help people we support to keep moving. Our first tip is that we can encourage exercise. Research shows that targeted exercise can help reduce falls for people living with dementia by building up strength and balance. People might be advised to try walking, Tai Chi, or a special falls prevention exercise program. So if someone's been set up with some exercises to do, or is going to go along to a class, we are their biggest cheer squad. When we're thinking about motivating people, reducing falls might not actually be what's important to the person, especially if they don't recognise that they're at risk of falling. We want to find out what motivates that individual. It might be something like, now these exercises will help you get up out of your chair more easily. That might make sense to them. Our second tip is that we can be open to opportunities. Tracy gave lots of examples, didn't she, of ways that we can slip movement into the day in the things we're doing. There are lots of activities that involve movement. Can we put some of those into our schedule together? We might even try walking, dancing, gardening, you name it. Can we encourage people to be doing as much as possible for themselves? The more people do for themselves, the more they can keep doing. One opportunity to think about is when people have been sitting in the same position for a while, they can get stiff, and that makes them more likely to fall when they get up. We want to help people to move or reposition themselves regularly. How about some exercises to help get rid of that stiffness before people stand up? I'll talk you through 3 simple exercises that can be useful before standing. You can try them out while I describe them. The first one is toe and heel taps. So for one foot, keeping your heel on the ground, lift the front of your foot up and back down. Then keeping your toes on the ground, lift your heel up and back down. We could do that 5 times for each foot. Now the next thing is just to straighten your knees one at a time. You could try that 5 times each leg. Gently march your knees up and down for 10 to 15 seconds. So when you're ready to stand, shuffle up to the front third of your chair and push up through your legs to standing. Gently stretch your back and neck by standing as tall as you can. Now hopefully you were doing these exercises along with us. How did it feel? Well, these might be really useful exercises to use with people you work with, particularly if you notice that they're a little bit wobbly when they first stand up. The third way we can help people living with dementia to keep moving is to address anxiety. Tracy talked about how people who've had a fall may restrict their activity because they're afraid of falling again. But this actually means that they lose strength and balance, and that increases their risk of falling. So if someone's had a fall, it can be really important to address their anxiety to help prevent that vicious circle. But you know what? We might need to address our own anxiety as well when we're working with someone who's a bit unsteady. Sometimes we can be a bit like a parent trying to teach their teen to drive. Watch out! Slow down! Don't do that! We mean to give a message about moving safely, but we may accidentally be giving the message, don't move. If we can, we want to be enthusiastic about the fact that they want to get up, but help them to pause. I might squeeze their hand and say something like, "What a great idea to stretch your legs, Mrs. Patel. Give me a moment, I'll get your walker sorted." Sometimes technology can help everyone's anxiety. For example, if someone enjoys walking outside, but there are concerns that they might get lost, there are wearable devices that can help locate them. You can find out more about these on the Wander Search website. There's also personal alarms available that have a fall sensor built in. So, we've thought about move. Now let's think about improve. We'll focus on needs, mobility aids, and medications. Our first question is, can we improve the way we're meeting needs? Across the Dementia STARs sessions and across our care plans, we look at lots of issues. Encouraging people to eat well, helping hydration, managing pain, being aware of sensory issues, spotting and preventing delirium, encouraging continence, and so on. The big picture is that all of these things are also helping to prevent falls. If someone living with dementia has unmet needs, then they may be more likely to fall. They might experience physical effects, like being dizzy from hunger, but they may also move less safely because they're agitated, or they get up impulsively to try to get it sorted themselves when they aren't actually safe to move on their own. Basically, anything that makes the person living with dementia stressed, distressed, or restless can increase the risk of falls. Some common triggers include being in pain, particularly for people who have foot pain or chronic pain, being hungry or thirsty, rushing to use the toilet, being frightened, bored, or lonely. So when we're thinking, is there anything they might need, from a drink, to having something to do, to having the TV on the right channel, we're actually thinking about falls prevention. The next thing we might be able to improve is how we're using mobility aids. How's that mobility aid working for them? Using a mobility aid like a walking stick or a walking frame, it's actually a tricky cognitive task. We have to remember to use them, and then we have to multitask to think about walking and using the aid at the same time. This means that mobility aids are a bit of a mixed blessing for people living with dementia. They can be a factor in increasing falls. So here are 4 questions we want to be ready to ask. Number 1, might the person need a new mobility aid? Are they holding on to things to move or finding it hard to get up out of their chair? Number 2, is the person using their mobility aid as it's intended to be used? Now, using a wheelchair as a walking frame, for example, well, that's creative, but it's really not a great idea from a falls perspective. Number 3, how should we leave the mobility aid when we leave the person unattended? And number 4, do we need a change? We might notice that a mobility aid that was a great help is now seeming a bit tricky. It might be time for a professional assessment or a change in our care plan. Now, you are a fantastic resource as eyes and ears, so if you do have concerns, bring these questions to the appropriate people who can get professional advice from an occupational therapist or a physiotherapist. Once we've thought through these questions, we want to make sure that this new mobility plan is documented and everyone is on board. The plan will say what mobility and transfer aids are needed, the level of assistance that they need, and what we've found helpful for that particular person. A third way we might be able to improve is medication. could their medication be a risk? Now, some medications can have side effects that increase the risk of falls. People living with dementia are more likely to be prescribed these types of medications, so we need to be alert. Dr. Matthew Croucher is going to explain a bit more to us.
So with what we're learning today about falls prevention with move and improve and remove, if we narrow down and think about that middle part, improve, I want to focus our attention on the part of that that's to do with medications. I think everyone knows that certain medications can increase our risk of falling, and particularly people living with a dementia illness, because there's something not 100% about how that person's brain is working. So when it comes to medication, some things are really obvious. So if a medicine is causing sedation, so that a person is just really sleepy, that person is not going to be able to walk safely. If a medicine is causing significant confusion, clearly that person is not going to be able to walk well. And also, if a medicine is causing someone's blood pressure to drop to their boots every time they stand up, you know that thing that we all get? If we jump out of a chair too quickly, we can come over a bit giddy. So if that is severe, well, the person will faint and fall over. And you may well know that some medicines can cause changes that look a little bit like Parkinson's disease, you know, where a person gets all stiff and hunched over and shuffling as they walk with a loss of balance. Now, I've been describing those problems as severe problems. And when they're severe like that, then the person's next door neighbour can work out that they're at higher risk of falling. You guys need to be able to notice when it's mild. So if someone is starting to look just slightly sleepier than normal, they're falling asleep a bit, perhaps at the end of a meal, perhaps even at the end of a conversation, and they didn't used to do that, that's something that you need to tell someone, because it will raise the risk of falling. If someone is just a little bit more confused than normal, but it's noticeable, and it's a definite change, that needs to be thought through. If someone is beginning to get a little bit giddy when they stand up, but they didn't used to, so they stand up and just several times a day they have to hold on to something. And if someone is just starting to look as though their walking is just smaller with its steps and a bit less free and moving, then that might be Parkinsonism beginning to start. So your job is to notice those things and to tell someone about it who can think about the prescribing and perhaps change it. What's the worst that can happen? The worst that can happen is that person goes, "Oh, thanks for that, I've checked them out and no, nothing there." But what if the person comes back, the registered nurse or the GP or the family member, and says, "Do you know what? We started a new medicine last week and the doctor thinks that's causing this problem you've just noticed. You may have prevented a fall." So that's what we need to focus on when it's hard to notice, but you're there, you notice, so it's about raising the alarm.
That may remind you of a situation where someone you know developed one of these side effects and ended up falling. So here's an example that might ring some bells for you. Jodie started working as a care worker with Mr. Green, helping Mr. Green to have a shower each day. Mr. Green was an older gentleman with dementia who was partly blind. After about 3 weeks, Jodie noticed a change. When Mr. Green stood up to come to the shower, he got wobbly and dizzy. He said he felt a bit woozy, and he joked that Jodie might have to be ready to catch him. Jodie found out that Mr. Green had had 2 falls in the last week, but luckily he hadn't hurt himself. Jodie thought about whether there'd been any changes, and she realised that Mr. Green was taking a new pill for his dementia. She talked to the duty nurse about what had happened, and the nurse checked out Mr. Green and let Mr. Green's GP know. And it turned out that that new pill, Donepezil, was causing Mr. Green's blood pressure to be very low. He changed to a different medicine and stopped feeling dizzy. So here's something for you to think about. In your job, who would you tell if you noticed a change that might increase the risk of falling that might be a medication side effect, even if you weren't 100% sure about it? So we've looked at move and improve. What about remove? We can remove hazards from the environment. I suspect that this might have been the first thing you thought of when you saw that our topic was falls prevention. Let's take a look at 4 types of hazard. Our first hazard is floppy footwear. Safe footwear has a good non-slip sole. It has a heel at the back to keep your foot in. It has some way of tightening the shoe, and it's not too old and worn. I think these shoes fail the floppy footwear test. The second type of hazard is things that the person might trip over. What's on the floor? Cords, rugs, and even really long clothes can be tripped over. Clutter can be tripped over. We want to have a clear pathway to the door or toilet. Even pets can be tripped over. Sometimes a bell can be helpful for a cat that insists on being under your feet. Our third type of hazard is situations where the person might lose their balance. One risk situation is going downstairs. We want to make sure there's a good handrail. Another danger spot is when a person climbs or stretches up to get something that's not easily in reach. We can think about what the person is probably going to want and make sure that those items are easily accessible. Our last type of hazard is not seeing hazards. Not being able to see properly is a real risk for falls. So we want people to be seeing the best they can. Have they got their glasses? Are their glasses clean? Do their glasses seem to be working for them? We also want the room to be well lit to help see those hazards. People living with dementia may need the room to be brighter than you do to be able to see well. How do we build this awareness of hazards into our daily workflow? Well, that's our next big idea. Look before you leave. Before we leave a client living with dementia unattended, we want to take a few moments to scan the environment and think about how we can move, improve, and remove to reduce falls. Let's imagine a couple of scenarios. Here's our first one. Your friend is sleeping on your sofa after having a bit too much to drink, and now you're heading to bed. You don't want them to fall when they wake up. What are you going to scan the room for? You might think of things like clearing a path to the door so they can get to the toilet and shifting that table, turning on some low-level lighting, providing a blanket for warmth, leaving instructions or put a note on the door if she doesn't know where the toilet is, providing some water, especially so she doesn't get a hangover, putting her phone nearby, or leaving her a note with essential information. Here's another scenario to imagine. You've just broken your ankle and you're having trouble getting around. You're settling in on the couch for a great night in. You really don't want to get up once you're cosy. How can you and your housemate make sure that you're set up for the evening before your housemate heads out? Some things that people think of will be pretty universal. Going to the toilet before you settle in, having a drink and snacks handy. You might have other things that you consider necessities, like a box of tissues, a heater, or your glasses. Most people would want to have their entertainment ready, but just what this is will vary. You might want your favourite TV program, or Netflix movie, or your book, or your knitting. These are examples of environmental scans. We want to do this kind of a scan every time we leave our client living with dementia unattended. On our website, you'll find an example of an environmental scan checklist. We've adapted this from Safely You. It's not only great for thinking about falls, It's also great for lots of other components of our care plans. So this is a handy to-do list. You're doing lots of great things already, but hopefully a little reminder like this can be really helpful. The final big idea for us to explore is learn from every fall. One of the ways to reduce falls in the future is to understand why the person fell this time. We want to learn from every fall. Just a reminder that if you do find someone on the ground after a fall, remember your training. Reassure the person. We're going to get down to their level on the ground. Rule out injury. Ring or call out for help. Rise and rest. So if they can safely rise, we can use the technique of the person getting onto their knees, and then they use a stable chair for assistance to get onto their feet. We don't try to pull them up or lift them on our own. Once they're up, we suggest that they rest in the chair for a while before they move any further. Rescue. If it isn't safe to help the person get up, the responders to your call would use equipment to safely move the person and help transport the person to hospital. The final step is that we always report the fall, even if the person is fine. So if you find someone who's fallen, you're going to kick in with that falls pathway. But alongside helping the person, you're going into FSI mode. That's like CSI, but instead of crime scene investigation, it's fall scene investigation. Are there any clues about why the person might have fallen? Your eyes and ears are going to be really useful for the team to work out what might have happened and how we can change the care plan to prevent future falls. What kind of information might be helpful for the fall scene investigation? What was the person trying to do just before they fell? What clues do we have about things that might have contributed to the fall? We could look through our Look Before You Leave checklist for ideas. Had the person fallen before? If they had, were all the falls prevention strategies we agreed on in place? If not, what was the barrier? Had you noticed any medication changes or changes in the person, like seeming weaker than usual or more confused than usual? This kind of information is going to be really useful for the team to come up with ways to help prevent more falls. We've covered a lot today, haven't we? And I think that's a reflection of how much we can all be doing to help prevent falls with people living with dementia. The take-home message is to think, move, improve, and remove. And when do we especially want to do this? We want to look before we leave, and we want to learn from every fall. Thanks for joining me today, and thanks for all you do to help prevent falls. Ngā mihi.
We hope you have found this Dementia STARs course valuable. We really appreciate the time you have taken to allow us to share some new ideas and fresh perspectives on this important topic with you. We hope you will return to your work with people living with dementia with renewed enthusiasm. It's such an important job, and you are a very precious part of the dementia family. The New Zealand Dementia Foundation would like to thank CHT Healthcare Trust for their generous support of this project. If you would like to learn more about the New Zealand Dementia Foundation's work, check out their website and join the community. This module is one of a series of Dementia STARs courses. You can find out more about the other topics from your workplace educator or on the New Zealand Dementia Foundation's website. Ngā mihi mai oha. Thank you so much for your commitment to people living with dementia.